so lucky, provided they get benefit of it.
I remember the first article I wrote, Kabir said, go to the British Council and, a fax by me, and then he was complaining, Mahmud, you made me pay so much money just to extract one article.
Yes, we had the same thing. Bilkul. No, for my one paper, believe me, I had to request somebody in the K Medical College, आगे library ना च मुंतज़ादा season लग रहा होलेगा. और भी ऐसी खमक के बजी that computer बनो मुंग बागा typewriter या बिया पे electronic typewriter मन मुंग लिखल कोल दागा यो community medicine की कसो अल्लाह को ने limping बम कोलो मुंग बटोल dissertation store paper दलम बखुशालो लो चिदा मुंग typing हो के यो word बगलत शो मुंग बटोल papers बिया दोबारा लिखा. That was
so come with some exercise and look at the paradigm shift that has come about. I'll just join you.
Marak, can you please unmute Dr. Nayab? She has joined already.
Right, I'm doing that. In this, which name?
Wait, I'll confirm.
I think it's the Samsung SMX216B something.
Can you confirm, please?
She has turned on her video so I can see her.
Okay, right. Ma'am, I've unmuted you. You can speak now.
Assalamu alaikum. Am I audible now?
Yes, ma'am.
Yes, perfect.
Okay.
Nayab, you try if you can have you are from the mobile or from your laptop?
No, sir. I'm from I am online through my tablet.
Okay, yeah, बिया बताओ उसका screen share ग्रांशी. Okay, ठीक है.
जी सर.
मावी कितनी तासो अगर presentation screen slides laptop in बिया के दो खोटेब ने बताओ उसका ग्रांशी. But stick, I think somebody else is.
असल के मुंगा laptop बांधे अगर वो कागा audible ना उन्हें ज़कर बिया ज़र पर tablet पे थ्रू बांधे रहा है online.
अगर probably तासो ता mute unmute कोलो rights नो दसरा ज़कर तासो नो मासरम दासो. Anyhow, no issue. I think somebody can play for you the slides. That's
yes, sir.
Yes, sir. I'll be playing the slide. Yes.
Yeah. Okay.
Hello. Assalamu alaikum, sir. Intekhab sab.
Assalamu alaikum.
Wa alaikum assalam. Thank you so much, sir, for being with us.
My pleasure. You're welcome.
Assalamu alaikum. Intekhab bhai kaise theek hai?
Alhamdulillah. Kaise Javed?
Alhamdulillah. Ivan.
ठीक ठाक. खैरियत. Looking nice.
Same here. हमारी तो खैर आपने कैसे अपनी जान फारिग मरीजों को शायद आपने उस पे पास पे डाल दिया है कि जरा
मैंने सुबह से कह दिया कि मैंने मगरिब के टाइम फारिग होना है.
ये होता है, बड़ा मुश्किल हो जाता है.
Dear sir, Mahmud sir, can we start?
सर मा ख्याल की चलता लगा सलाड़ो राजी मा ख्याल की तासो
तो सारा बेटा
if you could unmute.
म्यूट किया हुआ है शायद, तो उनको अनम्यूट कर दे and then you can start with this permission.
Right, sir. So he can now unmute himself.
Okay, fine. I've just been unmuted. Bismillah ar-Rahman ar-Rahim. I want to thank Dr. Iqbal Haider, our very, very able and worthy Associate Dean Research. As I just mentioned, that he's always full of very, very intriguing and innovative ideas, and we are putting them into practice. Today is the seminal or the inaugural session of the virtual Grand Round, and we have with us very distinguished speakers. Some of them are friends, some of them are colleagues, some of them are my juniors. I want to thank the young students also for their very enthusiastic participation in this program. I was obviously going to very much attend that. I'm so pleased that we are going ahead to us. I leave the floor to the rest of the speakers and to Dr. Iqbal Haider now. Thank you so much.
Thank you so much,
Thank you
sir.
so
Sara Beta, please welcome Professor Altaf Alam sir from Lahore. He's with us. Thank you so much, sir.
much. Okay, so we'll begin now. Assalamu alaikum, everybody, and a very good evening to everyone who is joining us from Peshawar and beyond. My name is Sara Yusuf. I am a student of Khyber Medical College, 4th year MBBS, and I am Vice President of the Student Research Committee. And it is an honor to welcome all of you to our new initiative, the Virtual Clinical Rounds. Today is the inaugural session of it. This series was born out of a shared vision to make the clinical learning more accessible, more relevant, and more interactive for medical students and for practitioners as well. And today we are officially launching it, and I would like to extend a heartfelt thanks to Dr. Iqbal and also the entire SRC team. Your enthusiasm and hard work and vision have turned this into a reality. I would also like to extend a heartfelt thank you to our esteemed Dean, Professor Dr. Mahmud Aurangzeb, for honoring us with his presence today as our chief guest and for his unwavering support. He's always been there. He's always supportive of our ideas. We thank you. And so today is our first session, and it is centered on a very significant topic of clinical relevance, one that we frequently encounter both in wards and in our communities. And it is related to the clinical management of hepatitis B virus. This session will cover diagnostic strategies, treatment protocols, and practical management tips from real-world clinical practice. We are incredibly honored to be leading this session as our speaker. Please join me in welcoming Dr. Nayab, who will walk us through the management of hepatitis B. She is a 4th year PG resident at Medical C Ward, KTH Peshawar. Alongside her, we have a brilliant panel of 3 clinicians and academics who will be contributing their insights today to today's discussion. Please welcome our panelists. First, we have Professor Dr. Altaf Alam. Thank you so much for being here. Professor Altaf Alam is a consultant gastroenterologist, hepatologist at Evercare Hospital, Lahore. Previously, he has served as an ex-professor and head of Department of Gastroenterology, Hepatology of Sheikh Zayed Postgraduate Medical Institute in Lahore. Thank you so much for being here, sir. Next, we have Dr. Intekhab Alam. Graduating with a distinction from KMC in 1987, he was the first best graduate and university gold medalist. He earned a fellowship in internal medicine in 1991, and during his 25 years at LRH, he served as chairman of the Department of Medicine and CEO of PGMI and chief editor of JPMI. Thank you so much, sir, for being here.
Welcome.
Next, we have Dr. Javed Iqbal Farooqi. He is a professor of medicine and gastroenterology at Life Care Hospital and Research Institute in Hyderabad, Peshawar. He also served as the president of Pakistan Society of Hepatology from 2017 to 2018. Sir, thank you so much for being here. Thank you for taking out your time. I know you guys, all of you have busy schedules, and thank you for joining us today. We look forward to hearing your expert perspectives throughout this session. Now, before we begin the clinical session, I'd like to quickly go through some housekeeping rules. First of all, please keep your microphones muted throughout the session to avoid any audio disruption. Secondly, this session is being recorded, so by attending, you consent to being recorded. Third, if you have any questions, please use the raise hand option, or you can send your questions directly in the Zoom chat box to the moderator. Number 4, and most important, please remain respectful in your language and engagement. This is a professional learning space, and we value a collaborative tone throughout. Thank you so much, everybody, for joining in. Now, we would officially begin our session. Dr. Nayab, the platform is now yours. Thank you.
Hello and good evening. My name is Dr. Nayab and I am currently working as a fourth-year postgraduate resident in internal medicine in Khyber Teaching Hospital, Peshawar. Today, I am pleased to be presenting the first session of virtual clinical round series on hepatitis B in 21st century, therapeutic advances and modern management, a subject that I believe is both timely and highly relevant to our clinical practice. I look forward to sharing insights, discussing evidence-based approaches, and hopefully engaging in a thoughtful exchange of ideas with all of you. Thank you for your attention, and let's begin. As a healthcare professionals in digital era, we are increasingly faced with well-informed and curious patients who ask essential and sometimes difficult questions regarding hepatitis B, like when should I start treatment? Will I have to take this therapy forever? Or is there a cure for hepatitis B virus, or is it just lifelong management? They are not just medical questions that are deeply personal concerns for patients. Today, in this latest evidence-based answers, exploring the concept of finite versus indefinite therapy, functional versus complete cure, and how current guidelines guide us through these decisions. Next, please. Smarak, can you please change the slide? We can go to next as well. The aims and objectives of this session is to review and compare the latest guidelines on the diagnosis, monitoring, and treatment of hepatitis B infection, to discuss indications and timings for antiviral therapy in different stages of hepatitis B virus infection based on guideline recommendations, and to highlight recommendations for special populations, including pregnant women, immunocompromised patients, and those with co-infections, and to promote discussion on applying international guidelines in local clinical practice settings and identifying any practical barriers. Next, please. A real-life case scenario which led us to ponder upon hepatitis B virus was a case of a young man who presented to our outpatient department for follow-up. He was diagnosed with chronic hepatitis B 3 years ago during routine health screening. At the time of diagnosis, his hepatitis B viral DNA was 1.5 into 10 raised to power international units per milliliter. ALT was elevated, and he was hepatitis B E antigen positive. A liver elastography showed F2 fibrosis. Based on international guidelines, tenofovir disoproxil fumarate was initiated. Despite 3 years of regular treatment and compliance, his most recent labs show hepatitis B viral DNA of 4.2 into 10 raised to power 2 international units per milliliter, ALT of 60 units per liter, hepatitis B E antigen negative. Patient insisted that he never missed a dose, and there were no co-infections present. There was no evidence of the drug resistance because the testing was done previously. Now, as the patient was on his follow-up, he was concerned about his lack of response to therapy and requests a second opinion, asking whether he needs a medication change or additional testing. Next, please. Hepatitis B virus or chronic hepatitis B virus affects over 250 million people globally. It causes significant morbidity and mortality from cirrhosis and hepatocellular carcinoma. And the effective management of chronic hepatitis B virus requires early diagnosis, risk stratification, and tailored antiviral therapy. There are some recommendations which are evidence-based from the major liver societies, including American Association for the Study of Liver Disease 2018, Asian Pacific Association for the Study of the Liver, and European Association for the Study of the Liver with its latest guidelines published in 2025. Next, please. Before commencing discussion on chronic hepatitis B virus management according to the guidelines, I would like to discuss phases of chronic hepatitis B virus. It has immunotolerant phase, immune active phase, inactive carrier phase, reactivation phase, and a resolved or occult phase. The immune tolerant phase, the hepatitis B E antigen is positive with normal ALT and very high viral DNA load with the liver histology showing minimal or no inflammation. The immune active phase has hepatitis B E antigen positive with elevated ALT and a viral DNA load of more than 20,000 international per units ml and liver histology showing moderate to severe inflammation. Whereas the inactive carrier stage has a negative hepatitis B E antigen with normal ALT and low viral DNA and minimal or no activity on the liver histology. The reactivation phase, in this phase, hepatitis B E antigen is negative with ALT elevated and a viral load of more than 2,000 international units per milliliter and an active inflammation of fibrosis shown on the liver histology, where in the resolve phase, all the parameters are undetectable or the liver histology is inactive. Next, please. Now that we have understood the phases, let's begin with what does the guidelines say about management. The AASLD guidelines, APASL guidelines, and EASL guidelines provide evidence-based framework for managing chronic hepatitis B virus. There are slight variations in the treatment depending upon the threshold and approaches due to regional differences and data updates. Next, please. Now, what does the AASLD says? According to the AASLD, for the patients with hepatitis B E antigen chronic hepatitis, the guidelines recommend treatment when the following conditions are met. Hepatitis B viral DNA of more than 20,000 international units per ml, and ALT should be more than 2 times upper limit of the normal. Additionally, the treatment is recommended when the hepatitis B viral DNA is more than 20,000 international units per milliliter with moderate to severe inflammation or fibrosis. In the case of hepatitis B antigen negative chronic hepatitis, the hepatitis B viral DNA should be more than 2,000 international units per milliliter and ALT 2 times the upper normal limit. And it should be treated if there is significant fibrosis or inflammation present regardless of hepatitis B viral DNA load or ALT. While the immunotolerant phase, AASLD guidelines say that treatment is not recommended unless age is more than 40 or significant fibrosis or inflammation is present. Next, please. Now we have APASL guidelines and EASL guidelines. The APASL guidelines for HBe antigen chronic hepatitis patients recommend that the patient should be treated when the hepatitis B viral DNA is more than 20,000 international units per milliliter and ALT is 2 times upper limit normal, and consider treatment if there is moderate to severe inflammation or fibrosis present. Whereas in the case of hepatitis B E antigen negative chronic hepatitis, APASL recommends that HBV DNA should be more than 2,000 international units per ml and ALT should be 2 times upper limit normal. While in the case of fibrosis or inflammation, treatment is necessary. In the case of cirrhosis, all the patients should be treated. While the immunotolerant phase, treatment is not recommended unless significant histological disease is confirmed. While the EASL guidelines, which are the latest guidelines published in 2025, the patients who are suffering from hepatitis B antigen positive chronic hepatitis, when HBV DNA is more than 2,000 international units per ml and ALT is upper limit normal, the patient should be treated. While treat the patient as well if the moderate to severe inflammation fibrosis is present. In case of hepatitis B E antigen negative chronic hepatitis B viral DNA with 2,000 international units per milliliter and ALT more than upper limit normal and significant fibrosis should be treated, while all the patients who have cirrhosis should be treated. However, in the immunotolerant phase, EASL guidelines are controversial. They say that treatment is not generally recommended, but may be considered in patients with more than 30 years with high HBV DNA and family history of cirrhosis or hepatocellular carcinoma. Change, please. This slide shows the comparative analysis of all the guidelines according to the ALT thresholds, HBV DNA thresholds, immunotolerant phase, and cirrhosis. AASLD uses gender-specific ALT cutoffs, that is 35 units per milliliter for males and 25 units per liter for females, while the APASL uses 40 units per liter for both genders, while EASL is more, in the EASL, the ALT threshold is more inclusive but lab dependent. HBV DNA thresholds according to AASLD and APASL, for hepatitis B antigen positive patients, the DNA threshold is 20,000 international units per ml, while for hepatitis B antigen negative patients, the threshold is 2,000 international units per ml. While EASL uses 2,000 international units per ml for both, thus lowering threshold for hepatitis B antigen positive patients. In the immunotolerant cases, AASLD guidelines and APASL guidelines advise against the routine treatment, while EASL suggests that the treatment should be considered in older patients, such as patients with more than 30 years and having risk factors. While in the case of cirrhosis, all the three guidelines, that is AASLD, APASL, and EASL, they suggest that all patients with the cirrhosis should be treated. Next, please. Now that we have understood the phases and have something about the management, the next important step is to initiate treatment and choosing the right therapy. Different international guidelines provide evidence-based recommendations on preferred first-line treatment. According to AASLD, it recommends nucleoside analogs such as entecavir, tenofovir disoproxil fumarate, and tenofovir alafenamide as the first-line therapies due to high genetic barrier to resistance. Pegylated interferon is an option but less preferred due to side effects, while APASL says that it recommends entecavir and tenofovir disoproxil fumarate, but TAF was not included due to limited data at time. PEG interferon, according to APASL, is an alternative but not first line. EASL recommends entecavir, TDF, and TAF, which are nucleoside analogs for chronic hepatitis B and cirrhosis. PEG interferon is considered for selected patients such as young, non-cirrhotic hepatitis B antigen positive with low viral load. No combination therapies are recommended as initial treatment due to limited benefits. Next, please. When the patient is started on different therapies, the most important thing is monitoring of those strategies and for how much duration we should give those medications. The monitoring aims to assess treatment response, detect virological breakthrough, and screen for complications like hepatocellular carcinoma. Although guidelines recommend regular clinical, biochemical, virological, and imaging assessments, still monitoring is vital for the medications which are given against chronic hepatitis B management. Next, please. So, for the patient who are on treatment for chronic hepatitis B antigen, monitored through ALT, hepatitis B viral DNA, and hepatitis B antigen (NTHBE) every 3 to 6 months. Check creatinine kinase and lactic acid if nucleoside analog-related side effects such as myopathy or lactic acidosis are suspected. For patients who are untreated, monitor ALT every 6 months in immunotolerant or inactive phases to detect transition to immune-active disease. Hepatitis B viral DNA and hepatitis B antigen and NTHB testing is considered if ALT elevates. For the patients who have hepatocellular carcinoma, surveillance can be done through ultrasound every 6 months. And although those patients who have high risk, such as Asian having more than age of 40 years, African more than 20 years age, and family history of hepatocellular carcinoma or elevated HPV DNA, HCC surveillance should be done by ultrasound every 6 months. While those patients who have already been treated, they should be monitored every 3 months for 1 year for viremia, ALT flares, or decompensation after stopping therapy. These were the guidelines suggested by the AASLD 2018. Next, please. According to APASL guidelines, for the monitoring for the patients who are on treatment should be done by monitoring of hepatitis B viral DNA, ALT, and hepatitis B antigen and NTHBE every 3 to 6 months. Also, assess the renal functions for the patients who are on TDF and CK for telbuvidine. For the patients who are untreated, monitor through ALT and hepatitis B viral DNA every 6 to 12 months in inactive or immune-tolerant phases. For the patients who are suffering from hepatitis C, surveillance should be done by ultrasound every 6 months in high-risk groups, such as having cirrhosis, high HPV DNA, or older age. And the patients who have already been treated, according to APASL, monitoring should be done every 3 months for 1 year to detect relapse. Next, please. Now the EASL guidelines. The most recent guidelines say that the patient who are on treatment for chronic hepatitis B, they should be monitored via hepatitis B viral DNA, ALT, hepatitis B antigen, anti-HBe, and hepatitis B surface antigen levels every 3 to 6 months. Quantitative hepatitis B surface antigen may guide discontinuation decisions. The untreated patients should be monitored through ALT and hepatitis B viral DNA every 6 months in inactive or immune tolerant phases. Non-invasive tests such as fibroscan can be done to assess the fibrosis. Those who are suffering from hepatocellular carcinoma, ultrasound should be done every 6 months, and those having high-risk patients or those with hepatitis B viral DNA more than 2,000 international units per ml. Those who have already been treated for chronic hepatitis B, monitor patients every 3 months for 1 year with emphasis on hepatitis B surface antigen loss and hepatitis B viral DNA with a lower limit of quantification that is less than 10 international units per milliliter. Next, please. Now, what about the treatment duration? According to AASLD, for the hepatitis B antigen positive non-cirrhotic patient, continue nucleoside analogs until hepatitis B antigen seroconversion occurs with undetectable HBV DNA, followed by 12 months of consolidation therapy. Relapse risk is high if stopped prematurely. For hepatitis B antigen negative non-cirrhotic patients, indefinite therapy is recommended until hepatitis B surface antigen is lost and as relapse is most common after cessation. For the cirrhosis, lifelong nucleoside analog therapy is recommended to prevent decompensation and hepatocellular carcinoma. While in the case of PEG interferon, AASLD recommends that it can be given for finite duration, that is 48 to 52 weeks, but relapse is frequent. Next, please. APASL guidelines suggest that hepatitis B antigen positive non-cirrhotic patients continue nucleoside analogs until hepatitis B antigen seroconversion occurs with undetectable HBV DNA and 12 to 18 months consolidation. Consider stopping after 2 to 3 years if hepatitis B viral DNA remains undetectable and ALT normalizes. Hepatitis B antigen negative non-cirrhotic patients, APASL recommends that treatment should be considered after continuation of 2 to 3 years of undetectable HBV DNA, stopping of nucleoside analog should be considered. And normal ALT with hepatitis B surface antigen loss in 20% patients or 2 to 3 of the Asian patients. In case of cirrhosis, APASL recommends lifelong therapy, while PEG interferon, in the case of PEG interferon, 48 weeks therapy is recommended, but there are high relapse risks. Next, please. EASL guidelines suggest that the treatment for hepatitis B antigen positive non-cirrhotic should be continued through nucleoside analogs until hepatitis B antigen seroconversion occurs with undetectable HBV DNA and 12 to 18 months of consolidation. Consider stopping if hepatitis B surface antigen loss is confirmed, that is, 2 measurements are taken 6 months apart. In case of hepatitis B antigen negative non-cirrhotic patients, consider stopping nucleoside analogs after 2 to 3 years of undetectable hepatitis B viral DNA, normal ALT, and hepatitis B surface antigen of less than 100 international units per ml, aiming for partial cure, which is sustained hepatitis B surface antigen loss of less than 100 international units per ml, and hepatitis B viral DNA of less than lower limit of quantification of treatment. In patients who have cirrhosis, lifelong therapy is recommended, while EASL recommends recommendations for PEG interferon is that of the treatment of 48 weeks with careful patient selection due to side effects. Next, please. Now we have here some terminologies which we should be considered before moving on to the next slides. What is lifelong versus finite therapy? According to AASLD, it leans towards indefinite therapy for hepatitis B antigen negative patients and those with cirrhosis, while APASL and EASL allow discontinuation in selective non-cirrhotic patients with sustained response to hepatitis B surface antigen loss. Hepatitis B surface antigen loss is defined by EASL as a functional cure defines functional cure as a sustained hepatitis B surface antigen loss and hepatitis B viral DNA of lower limit of quantification, 24 weeks of treatment with or without anti-HBs, and emphasizes that hepatitis B surface antigen should be less than 100 international units per ml as a partial cure endpoint. All the guidelines, that is AASLD, APASL, and EASL recommends 12 to 18 months of consolidation after hepatitis B antigen seroconversion. But EASL and APASL allow earlier cessation in hepatitis B antigen negative patients with low hepatitis B surface antigen. Next, please. Now, if patients who are poorly managed with hepatitis B virus or are untreated, some complications can occur, such as cirrhosis, hepatocellular carcinoma, virological relapse, or acute on chronic liver failure. Acute on chronic liver failure is rare but severe and often triggered by reactivation or flares. While in case of virological relapse, recurrence of HBV DNA after stopping therapy can occur, and it can potentially cause hepatitis flares or decompensation. Next, please. The treatment which we have discussed till now, those therapies have some of the side effects as well. Considering nucleotide or nucleoside analogs such as entecavir, tenofovir, disoproxil fumarate, and tenofovir alafenamide, or lamivudine, telbuvudine, adafenofir, we have some of the side effects. Entecavir causes lactic acidosis, headache, fatigue. The resistance is low. TDF can cause nephrotoxicity, osteomalacia, bone density loss, and therefore renal function should be monitored while starting patient on this therapy. Tenofovir alafenamide, although is less renal and bone toxicity is less as compared to TDF, but it can increase low density lipoprotein cholesterol, and it can rarely cause lactic acidosis. Lamivudine, telbuvudine, adafovir, these are not first line due to resistance, and these have high resistance rates. While the PEG interferon, it can cause flu-like symptoms, it can cause bone marrow suppression, neutropenia, nepropsychiatric effects, depression and irritability, weight loss, and autoimmune disorders. PEG interferon is not recommended in decompensated cirrhosis, organ transplant, or severe neuropsychiatric conditions. Next, please. Now, how to manage the side effects? Monitor renal functions such as creatinine, estimated glomerular filtration rate, and bone health for tenofovir disoproxil fumarate. Check creatinine kinase and lactic acidosis if myopathy or lactic acidosis is suspected. Switch to tenofovir alafenamide in patients with tenofovir disoproxil fumarate related renal or bone toxicity. Confirm nucleoside analog related side effects with clinical evaluation and consider switching to another high genetic variant nucleoside analogs. For example, entecavir to tenofovir alafenamide. Next, please. Now that we have some of the special populations, and in those populations, chronic hepatitis B virus is common as well. Those special populations include pregnant women, lactating mothers, chronic patients with a chronic kidney disease or liver disease. Let's discuss what the guidelines says about the management in the pregnant woman. According to AASLD, initiate TDF in the third trimester for women with hepatitis B viral DNA of more than 2,000 international units per ml to reduce perinatal transmissions. Discontinue at delivery or up to 4 weeks postpartum to avoid postpartum flares. Infants should receive hepatitis B vaccine and hepatitis B immunoglobulin within 12 hours of birth. TDF is preferred over lamivudine or telbuvudine due to lower resistance. No significant increase in prematurity or congenital malformations are known till today. According to APASL guidelines, the guidelines are same as that of AASLD, and it recommends TDF for hepatitis B viral DNA of more than 200,000 international per unit ml in the third trimester. While there isn't expanded eligibility for antiviral prophylaxis in pregnant women with hepatitis B viral DNA of more than 200,000 international units per ml, TDF or TAF is preferred. It emphasizes simplified algorithms for resource-limited settings. Next, please. Now, in lactating women, AASLD suggests that nucleoside analogs are safe during lactation with minimal drug levels in breast milk. So continue the therapy if indicated for maternal health, for example, cirrhosis or immune active disease. Apacil has limited guidance, but it supports TDF use during lactation. EASIN explicitly states breastfeeding is safe with nucleoside analogs aligning with WHO recommendations. Monitor infant for adverse effects, though risks are negligible. Next, please. Now, in patients with chronic liver disease, AASLD recommends that all the patients with decompensated cirrhosis or compensated cirrhosis, regardless of hepatitis B viral DNA or ALT levels, should be treated with entecavir, TDF, or TAF. PEG interferon is contraindicated in decompensated cirrhosis. Reasons suggest to treat all the cirrhosis patients with entecavir, TDF, or TAF, and it emphasizes HCC surveillance. Ultrasound every 6 months and non-invasive fibrosis assessment should be considered. Apacil suggests that all the cirrhotic patients should be treated with entecavir or tenofovir disoproxil fumarate, and HCC should be monitored, and the patient should be monitored for hepatocellular carcinoma and decompensation. Next, please. Chronic kidney disease. AASLD suggests that the tenofovir disoproxil fumarate dose and entecavir doses should be adjusted based on eGFR. Tenofovir alafenamide is preferred in CKD due to lower renal toxicity. Monitor renal function every 3 to 6 months. Apacil recommends dose-adjusted TDF for entecavir. There is limited data on tenofovir alafenamide. ACEL prefers tenofovir alafenamide for CKD patients due to better renal safety profile. Monitor eGFR, phosphate levels, and for Fanconi syndrome with TDF. The key point is that TAF is preferred nucleoside analog in CKD, and avoid tenofovir disoproxil fumarate in advanced chronic kidney disease with the eGFR of less than 30 ml per minute unless no alternative exists. Next, please. Another important population, the oncology patients who are at the risk of HPV reactivation. According to AASLD, screen all patients for hepatitis B surface antigen and anti-HPC before immunosuppressive therapy, such as chemotherapy or biologics. Prophylactic nucleoside analogs for hepatitis B surface antigen positive patients or those with anti-HPC positivity undergoing high-risk regimens should be considered. Monitor hepatitis B viral DNA and ALT every 3 months during and for 12 months after immunosuppression. Apacil recommends screening and prophylaxis with entecavir or tenofovir disoproxil fumarate for hepatitis B surface antigen positive patients or anti-HPC positive patients at high reactivation risk. Monitor viral DNA during therapy. ACEL suggests universal screening for hepatitis B surface antigen and anti-HPC. Prophylactic nucleoside analogs for hepatitis B surface antigen positive patients and high-risk anti-HPC positive patients should be considered. Continue prophylaxis for 12 to 18 months after immunosuppression ends. Next, please. The current HPV therapies suppress viral replication but fail to eliminate covalently closed circular DNA or integrated hepatitis B viral DNA. Limited functional cure, that is hepatitis B surface antigen loss. Novel therapies aim to overcome this by targeting different mechanisms, including capsid assembly modulators, which disrupt viral capsid formation, and RNA interference, which reduce hepatitis B surface antigen production by targeting viral messenger RNAs. Next, please. There are some novel therapies, other novel therapies as well, such as which include entry inhibitors, immune modulators, therapeutic vaccines, checkpoint inhibitors, TLR agonists, and covalently closed circular DNA targeted therapies. These all different researches different trials are underway on these therapies till date. Next, please. Now, what are the future treatment prospects for chronic hepatitis B viral DNA? Important is combination therapies. It includes combining nucleoside analogs with capsid modulators, RNA interferences, or immune modulators to achieve synergistic effects on higher rates of hepatitis B surface antigen loss. Important term in the treatment prospects is functional cure. It is defined as sustained hepatitis B surface antigen loss and hepatitis B viral DNA with lower limit of quantification, that is less than 10 international units per ml, 24 weeks of treatment with or without anti-HBs. Current trials aim for 20 to 30% functional cure rates in non-cirrhotic patients. While the complete cure is defined as the elimination of covalently closed circular DNA and integrated hepatitis B viral DNA. This still remains a challenge due to a lack of standardized assays and therapies targeting these reservoirs. And this can only be achieved after 10 to 20 years. Next, please. Now, the main question of our patients, is HBV a curable disease? The current status says that HBV is not a curable disease with existing therapies due to persistent covalently closed circular DNA and integrated hepatitis B viral DNA, but functional cure is achievable in the minority. Future is bright with the novel therapies targeting covalently closed circular DNA combined with immune modulation and other therapies. It can achieve functional cure in 30 to 50% of patients by 2030 or 2035. Particularly in non-cirrhotic hepatitis B antigen negative patients with low HBs antigen levels. The phase 3 trials of combination therapies are expected to report results by 2027 to 2030, potentially leading to new approvals. Next, please. These are some of the ongoing clinical trials in HBV till July 2025. This includes REVEAL. It is in phase 2 trial, and be clear, this is also phase 2 trial of bepiroviricin plus nucleoside analogs targeting functional cure. Next, please. These are also some of the clinical trials in hepatitis B viral management. Next, please. This slide summarizes the discussion on practical management and approach, and it includes diagnosis and risk stratification. This is particularly important in our patients who, the patients who usually present to our settings in Pakistan. This practical management approach includes diagnosis and risk stratification, which should be followed by treatment initiation. Then next, then the duration of the treatment should be considered. And then there is safety of the treatment in the special population can be considered. Next, please. Next. While current therapies are effective at viral suppression, a true cure remains ultimate goal. We can say that the future is bright, but the complete cure of hepatitis B virus is still unknown, and the ongoing research brings us closer every day. Thank you all for your time and attention. I'd be happy to take any question or hear your insights. Thank you.
Thank you so much, Dr. Nayab, for an exceptionally informative and clinically rich session. Now I'd like to request Dr. Javed Farooqi to please share his thoughts. And we'd like to ask you some questions as well that are in the chat.
Thank you. Yeah, thank you very much, KMC team, Iqbal, Heather, and this all goes right to the Dean. It was an excellent initiative, and I think a very excellent review of the all concerned points by the Dr. Nayab. Yes, this is a everyday clinical practice, and this is the very common scenario that patients coming to you and they expect. You see, the problem comes the hepatitis B and C. This is probably the we people that we know that hepatitis C is curable and hepatitis B is just controllable. And when patient comes, they don't really feel the difference between B and C. And what we have seen, I have seen that even our colleagues, when the PCR becomes negative in hepatitis B, they stop treatment. It should be emphasized that hepatitis B is just like diabetes, hypertension. You have to control the disease unless you control it, you get the HbA antigen loss, which is really a dream by the current therapy. You cannot stop. Once you start, you have to continue it. And now there was one small area where we could think about the stopping, and that was with normal liver, no fibrosis, and patient being on enough treatment after the PCR becoming negative. But now the upcoming guidelines are suggesting even that in those cases also you shouldn't stop, because once you stop, there is chance of flare, and the flare may take away a patient from you. So I think we'll be expecting the questions by the audience, and of course the more pearls of wisdom by Professor Altaf Saab and Professor Intekhab Saab.
Sir, if you'd like to answer this question, is there any consensus HPV guidelines at Pakistan level?
Oh, yes. You see, Alhamdulillah, yes. In Pakistan, most of the, in cases we are following the EASL guidelines. The APASL, yes, we used to follow those in the early days, but no, to me, personally, I like the EASL guidelines too much. They are more practical, they are more comprehensive, and they are more sorts of covering all the aspects. The WHO guidelines appeared last year, and the reason is that we have got the task of WHO assignment to us 2030 to eliminate hepatitis B and C from the world. And we know that we are leaders in hepatitis C in the world, and we are in the top 3 or 4 countries with hepatitis B as well. So basically, this challenge is for Pakistan. And when the WHO guidelines came, they really widened the indications area. Initially, there was a difference between hepatitis B and C. For C, it was a common saying that treat each and every patient until it's contraindicated. And for hepatitis B, we used to say start treatment only if it is indicated. But now the spectrum is being widened, and especially the immune tolerant phase, where you said that there is controversial, there is almost no controversial now that we are now including more and more patients to get that target. And when we will discuss, the figure is now come down, the peculiar scenarios where even the ALT and the PCR viral load has no meaning, and you can start patients on treatment there as well. So in Pakistan, yes, we are sorts of having a mix of these. Those who are applicable to Pakistan, we are following those guidelines, and we have different forums, the PSG, the PSH, and the PWCLD, and we have got one uniform form, that is the HepNet, and which is producing the customized, so you can say the tailored sorts of therapy for hepatitis B, C, and others in Pakistan. And hopefully we'll be having those guidelines very soon, the published form. So yes, there are a mix of that. We are not strictly following any one guideline, go for AASLD or go for EASL, go for APASL. We are having the one which are applicable to our community, to our patients, and of course to the convenience of our every physician, the primary care physicians, and the specialists and the internists.
Thank you so much, sir. Sir, question, is there any guidelines regarding treatment of patient with hepatitis B core AB positive, negative PCR, and chemotherapy or immunosuppressive therapy?
I think that question has been answered in the last portions of the slides.
Okay.
Simple answer is yes. You have to
Okay.
prevent the reactivation of these patients, because even those who get HbA antigen negative, there is a chance that they can become reactivated, and the HbA antigen, even it may appear. So don't be happy that my patient HbA percentage is negative. If the immunity is lost, they can reactivate.
Okay, thank you so much, sir, for your thoughts.
Thank you.
Dr. Altaf Alam, if you would like to share your thoughts, and we'd like to ask you some questions as well. On to you.
Thank you very much. It's a pleasure seeing the Dean of KMC present throughout the presentation, which is very commendable. It's nice to see my friends Intekhab Alam and Javed Farooqi and Iqbal Haider. And I would congratulate Dr. Sara for conducting the session so well, and Dr. Nayab for presenting, having the courage to come up on the screen and presenting the such a difficult topic in such a nice way. I have a lot of things to say. I don't know where to start and where to finish. Now I can see the case scenario in front of me. I would like to emphasize one point here, that Delta virus was not checked. So this is the biggest mistake that we keep on making, not only in Pakistan, but worldwide. Any person who is surface antigen positive should have anti-HTV testing. And if positive, Delta RNA should be checked quantitatively and treated because these patients deteriorate very rapidly. In this scenario, once again, after 3 years of treatment, the patient was compliant, and DNA is 4.2 into 10 raised to the power 2 international units, which, according to my mathematical knowledge, although limited, is only 420 international units. So in my opinion, this is good control. Why are we worrying about this patient for second opinions and for switching or add-on therapy? This is an adequate control, and we should continue with the therapy. About the treatment selection, I would say that the things are going to become simpler. The WHO and Chinese guidelines were not highlighted in this presentation, but they are trying to make it very simple and straightforward. So yes, all patients, e antigen negative or positive, should be with a viral load of more than 2,000 and ALT of more than upper limit of normal should be treated. But what about the borderline cases where ALT and or viral load is somewhere in between? This is a difficult scenario, and the upcoming ASLD guidelines, which will be presented in the ASLD meeting in November later this year, they have already leaked the draft of their guidelines, and it suggests that immune tolerant and borderline cases should be treated after mutual discussion with the patient. It also simplifies the stopping rule that in e antigen negative or positive, non-cirrhotic, do not stop therapy until surface antigen becomes negative. So again, this will come up in the ASLD guidelines. We already know that from the draft that has come up to us, and we should consider stopping only if surface antigen becomes negative. In cirrhosis, even if surface antigen becomes negative, I would continue treatment because this is an immunosuppressed state, and reactivation, if occurs, it will be lethal before we know or before the patient comes to us. So there are a lot of new developments, and I wish we had incorporated WHO and Chinese guidelines, and we can take good points from all these guidelines and use it in our practice. So thank you very much. This is all I had to say as far as my comments are concerned. Thank you.
Sir, there is a question. Is there any concept of AVT and acute hepatitis B in recent RCTs?
Yes, yes, it has always been there. So in prolonged or severe acute hepatitis B, defined as INR of more than 1.5, impending or present encephalopathy, you should always treat. So yes, the answer is yes, with capital Y.
Okay. Thank you, sir. Sir, there is another question. Can we decide on just high ALT and HPV viral load more than 2000 to start treatment for HPV, irrespective of HBE, AG status in LMIC like Pakistan? Sorry, sir, I am a student, so I don't really understand these abbreviations.
I understood what you want to ask. Yes, e-antigen checking or anti-HBE checking is not mandatory according to Chinese and WHO guidelines. But having said that, both these guidelines, when they come to talk about stopping treatment, the duration of treatment, again talk about e-antigen positivity or negativity. So I would recommend continue to do it until things become simpler. So yes, I would suggest in 2025, although not mandatory, if not available, that is fine. ALT and DNA is sufficient. But if available and if affording, one should go for it.
Okay, thank you so much, sir, for your remarks. Now we are on to Dr. Intekhab Alam. Sir, the stage is now yours.
I would like to thank the KMC team, the Dean, and very nice to see Altaf Sahab, Javed Iqbal. Thank you very much for inviting me. Well, as it is said, once HBV, always HBV, right? So as it has been already been discussed that the dynamics of both HCV and HBV are completely different. And both are different ball games. HBV treatment, as Dr. Altaf Sahab has very... Hello, I'm audible?
Yes, sir.
Hello?
Yes, sir. Sir, you're audible, sir.
Sure, sir.
As Altaf Sahab has very vividly clarified, the simplified version of WHO guidelines and also the Chinese guidelines, in which they are very simply say if DNA level is more than 2000 and ALT is more than upper limit normal, not 2 times upper limit normal, just upper limit normal, regardless, it is a starting therapy. Regardless HB antigen status, you should start. But as it has been highlighted that it is very important to know HB antigen status to stop the therapy. Because in HB antigen positive cases, once the seroconvert from E antigen to E antibody, I mean, that is the time that you should, and HBV DNA becomes negative, ALT becomes normal, that is the time you should start thinking of stopping the therapy. In E antigen negative patient, on the other hand, it is difficult because there is no seroconversion which can be observed. But if DNA becomes negative, ALT normalizes, after giving 1 or 2 years of treatment, one can think of stopping treatment after giving them 1 year of consolidation treatment. And after that, they have to be told very strictly that strict monitoring is very important. Every 6 months, the ALT level, if possible, HB DNA level have to be checked. So in case of any relapse, they can be timely treated. So it is very important that we not only look for HBs antigen, but even HBC antigen antibody is very important. In patients who are HBs antigen negative, if they are anti-HBC antibody positive, they can relapse any time in future. So as I said, once hepatitis B, always hepatitis B. These patients need to be under your control for the rest of their life. Similarly, another important point is that when we start patients with hepatitis C on DAAs, we don't check their HBs antigen status. Number one, we must do that. And secondly, it has been shown that DAAs can reactivate hepatitis B. So if the patient turns out to be HBs antigen positive or even only HBC antibody positive, and you are starting them on DAS for hepatitis C, you can co-treat them with in high-risk patients with hepatitis B treatment as well. And I would have liked that in the presentation by Dr. Nayab, I wish he should have discussed the non-invasive fibrosis scores, FIB4 and APRI. They are very, very useful scores, which are very simple and to be calculated. And they show you quite not in that detail like elastography, but they give you an idea about fibrosis, and you can start treatment on, like, for example, FIB score is more than 2. It shows F2 fibrosis plus. So even if ALT is normal, FIB2 is more than 2, one can think of starting treatment for HBV. So I think that we should incorporate in our clinical practice FIB4 and APRI score, which are a very, very simple scoring system, and they are very helpful. And if there is but they are less sensitive in deciding between F1 and F2 fibrosis. For that, then elastography or fibroscan is the best method of choice. So that is what I wanted to say, that even patients who are being started on DAS for hepatitis C, a check should be kept on hepatitis B status as well. And as very rightly has been discussed, that we, by adopting the simplified version, we will increase the ambit of treatment for patients who fall in gray zones. Like there is quite inconsistencies between AASLD, EPASL, and EASL. So WHO is more of, they're taking the side of the EASL guidelines, and they're trying to bring into the ambit of treatment more and more patients. Secondly, we are now facing educated and informed patients. It is very difficult to deny them treatment if they are HBV DNA positive. So if there is no harm in giving them the treatment, it is only the cost which matters. So I think because they still insist for treatment because they are DNA positive. So we should think, as Dr. Altaf Alam have said very nicely said, that in future probably these gray zone areas should be discussed and brought in the ambit of treatment for hepatitis B treatment. Thank you very much.
Thank you, sir. Sir, there's a question in the chat box. Does the carrier state mean that there is no inflammation going on or still can develop cirrhosis? Another is that a patient already on treatment will develop cirrhosis or not. If cirrhosis is inevitable, it means that treatment can only prolong the stable state. Also discuss the co-infectivity, any choosing priority between Intekhab and tenofovir.
Yeah, I think as far as the co-infection is concerned, hepatitis B and C, both of them should be co-treated if they are coexisting. For HIV treatment as well, for example, if that is coexisting, the combination of tenofovir and Intekhab both should be tried in them. As far as sorry, what is the second part of the question?
Sir, it was the priority between the two drugs and discussing of the co-infection.
I think both are equally effective, and but the Intekhab has some degree of resistance development, 1 to 2% after 4 or 5 years of development. And if the patient is on Intekhab and they are developing resistance problem, they should be switched over to tenofovir. And nowadays we have got tenofovir alafenamide, which has got more intrahepatic concentration as compared to the serum concentration. So I think we should be, if choice is given, tenofovir alafenamide should be my choice for the treatment.
Thank you, sir. Sir, another question is there any possible treatment option for Delta virus if detected as a co-infection with HBV?
Yeah, if there is a co-infection with Delta virus, then it should be treated with pegylated interferon for 48 weeks. That is the recommendation.
Sir, there's another question in the chat box. How to manage occult HBV in our setup?
How to manage?
Occult HBV in our setup.
Sorry, there is some voice noise problem.
Sir, Intekhab, She wants to ask regarding the management of occult HBV, which means
occult HBV, yeah. As I said, that in occult HBV need attention in special circumstances. For example, the patient is, for example, being put on anti CD20 treatment, for example, rituximab. We know we are using a lot of rituximab nowadays in rheumatology and hematology as well. So, but I'm seeing that probably these patients are not being checked for HBs antigen. What to talk about anti-HBC antibody? It's mandatory that they must be looked for. And as I said, that people who have got anti-HBC antibody positive, they should be treated if they are immunocompromised. Otherwise, there is no role of treatment, but they should be kept under observation.
Thank you, sir. Sir, there's a last question. Among current treatment choices, which is financially more feasible for our population?
Well, nowadays generics are available, and both tenofovir and Intekhab are quite, they are in affording prices, and long-term treatment is possible. Previously, it was pegylated interferon, which was very expensive, had a lot of side effects, and it was contraindicated in cirrhosis. But the present day treatment is very safe, affording for everybody, and long-term treatment can be given.
Thank you so much, sir. That ends our Q&A session. Now I request Dr. Iqbal Haider to kindly share his views.
Thank you so much, Sarah Beta. My SRC team did an excellent job, and special kudos to Dr. Nayab. She prepared the presentation in a very limited time span. I'm always grateful and indebted to my mentor, Professor Intekhab Alam Sahab, who is always with us in just a single phone call, and Professor Javed Iqbal Farooqi Sahab, my elder brother, always with me. Thank you so much. Sir Altaf Alam, thank you so much, sir. It's nice to see you after such a long time. You are a blessing for us, and your core knowledge and expertise matters a lot. We know the topic was difficult, and we intentionally have opted for topics which are difficult to manage, because TMOs and we even as a consultants are facing problems when we are dealing with these patients. So I'm taking the opportunity and asking a question from Professor Altaf Alam Sahab, if he is here. Sir?
Yeah. Yes,
Sir?
I'm here.
Yes, sir. Sir, thank you so much again. I know it's a very busy schedule for you, because in Peshawar, most people are not busy at this moment of the night, but I can understand your busy schedule. Sir, some of the hepatologists are practicing dual DAs in the management of chronic HBV. So for trainees, I want to know your wisdom pearls in that perspective.
I'll give a very short answer. There is no role of combination therapy so far. But having said that, the current guidelines, both EASL and Chinese guidelines, are now recommending adding interferon, pegylated interferon, when the response is not good or surface antigen loss is not coming up, particularly in those patients where surface antigen quantitative is low. And there the results have shown that either sequential or combination of NA and interferon produces the desired results of surface antigen loss in more cases than in those in whom a single therapy was continued. But in general, there is no role of combination therapy. Thank you.
Thank you so much. Over to Sarah. Please proceed now.
Thank you so much. This brings us to the end of today's session. Before we close, again, I'd like to take a moment to extend my heartfelt thanks to everyone who made it to this session and who joined today, especially to our speaker, Dr. Nayab. Thank you so much for joining. To our esteemed panelists, once again, thank you so much. And finally, to our honorable chief guest and our beloved dean, Professor Dr. Mahmud Aurangzeb, thank you so much for being here. And this was just the first one. We're trying to lay the foundation for the future coming ahead. And inshallah, we're going to have more such events in the future. Next week, we're going to have another one. And I expect everybody to join. And I guess have a good night. Thank you so much.
Sarah beta, not next week. It will be next month, inshallah. So Altaf Sahab, Sir Intekhab and Sir Farooqi, we will bother you again and again, and we'll take advantage of your expert and mentorship and all the perspective. I also want to express my gratitude to our Honorable Dean Professor Mahmud Sahab, who is being a surgeon, but he keenly attended this whole session. I know it was too much boring for him because we are just discussing.
No. It wasn't boring at all, Iqbal Haider. If I may just add a word or two. I, first of all, did not acknowledge the presence of Professor Altaf Alam Sahab. So thank you so much for taking time out and being a part of our inaugural session of our virtual Grand Round. It takes me back many, many years when I was a senior house officer at the Hammersmith Hospital in London, doing part of my surgical rotation, when a sort of news spread in the hospital that Dame Sheila Sherlock from the Royal Free Hospital is coming to give a lecture. And I said, who the hell is this woman? And then I found out that really she was responsible for branching off gastroenterology into then hepatology. And I heard her speak, and such a compelling woman. She was rather rude in the question answer session, but no, I do have an interest, and I want to accolades to Dr. Nayab, to the SRC team, to you, all the speakers, my good friends Javed Iqbal Farooqi and Intekhab Alam, who have shared their insights with me over a long period, and has shared a lot of his books also. And I hope that Altaf Alam Sahab can visit Khyber Medical College sometime. I would love to host him. We are the third oldest institute in the country of medical teaching and excellence. Thank you all very much. This was absolutely wonderful. I enjoyed the session thoroughly.
Thank you so much, everybody. Allah Hafiz, Shab Khair.
Good night.
Good night. Khuda Hafiz.
Khuda Hafiz. Thank you so much, everyone.
Allah Hafiz.